my name is Hunter Deaton. I am an osteopathic medical student, third year at Lincoln Memorial University. I'm currently rotating at Magnolia Regional Health Center as my core site, and I am presenting on behalf of my awesome residents and attendings listed here. So today I would like to present to you a case of GBS-induced Cauda equina syndrome in the setting of DKA. The patient presented to us with the main complaints of back pain and lower extremity pain. Of note, she came to the hospital previously with similar symptoms, but she left against medical advice before we could do a further workup. But on this admission, the patient continued to have low back and extremity pain, but the picture was blurred by the admission for diabetic ketoacidosis. She had a glucose of 471. She additionally met Surg criteria with a heart rate of 115, a respiratory rate of 36, but no source of infection was identified on initial presentation. Something concerning that came up across the first day of questioning with the patient was that she had urinary retention. So that really, sent our red flags up and concerned us for possible infection involving the spine. And then further questioning also revealed that she was an IV drug user, had needle sharing history. So this further blurred the case about where this infection was coming from. We did a blood draw and we found that she was positive for group beta strep. We ordered an echocardiogram thinking possibly endocarditis, but this came back negative. There were no valvular vegetations identified. So since the patient had lower extremity weakness and pain, and then on exam, she had point tenderness along the thoracic spine, and then the red flag symptom of urinary retention, we went ahead and ordered a CT scan and an MRI of the spine to rule out osteomyelitis. Imaging came back and showed osteomyelitis in the L5 to S1 region, and it also showed an abscess in the paraspinal muscles running from L3 to the mid-sacral region. And then further, an ascending epidural abscess was identified that went from the entire thoracic spine up into C2, and that was causing displacement of the spinal cord, and it caused severe canal narrowing. So on diagnosis, we came up with a spinal epidural abscess caused by group B strep, presenting with symptoms of Cauda equina syndrome. Those including leg and back pain, paresthesias, bladder dysfunction, and saddle anesthesia. The patient was sent to neurosurgery for emergent evaluation and surgery, and it reportedly is doing well today. So spinal epidural abscess, it's most commonly presents with cord compression symptoms, like I said, numbness, pain, weakness, bladder dysfunction. Some patients sometimes only require supportive care, antibiotics, and others require the emergent neurosurgery treatment, like our patient. Most epidural abscesses reported in the literature, from what we read, are due to hematogenous spread and are usually caused by Staph aureus. But in our case, what made it interesting was the bug that was causing this, group beta strep, because that was not as widely reported in the literature. Also, the presence of DKA kind of blurred the picture because you can have the abdominal and back pain. And so it made it harder to identify what was causing these symptoms. So what we learned from this case was that despite the prevalence of back pain in the United States, it may be easy to brush it off as just normal musculoskeletal back pain. But we came to the fact that all back pain should be evaluated appropriately because we want to rule out these causes like spinal epidural abscess that can cause permanent neurological deficits and eventually death. So in summary, the spinal epidural abscess should be ruled out, especially in those with risk factors with recent trauma, surgery, IV drug use, and then symptoms of persistent back pain, paresthesias, and bladder dysfunction. So thank you.
Thank you very much. That is an incredible catch. Very good. I'm sure the patient appreciated it as well. I'm just curious, because the progression is very well detailed in your case presentation. I'm just curious what the timeline was to surgical intervention from initial presentation.
I think it was just a few days or so. She came in, we treated the DKA. So I think it was about 3 days into when we were like, we need to get imaging because the back pain is pretty serious. She's had this before. We want to rule it out. And then immediately that day, she was sent to another hospital because we do not have neurosurgery there. Yeah, same day we got the results back. So,
Okay.
yeah.
Well, again, very good catch. So thank you for sharing that with us and for the reminder of the importance of imaging.
Yeah.
So are there any questions from the room? All right. Well, thank you very much.